Cohort 4 of the Clinical Quality Improvement Program. Thank you for joining us. My name is Philip Fourie. I'm one of 4 program faculty members of CQIP's 4th cohort and also hold the role as Deputy Chief Medical Officer for the Saskatchewan Health Authority. Today is a day to celebrate the commitment and efforts of our Cohort 4 CQIP participants, and we're delighted that you could join us in that celebration. This Capstone event will be an opportunity for our Cohort 4 participants to share the quality improvement work that they've done over the last 18 months, reflect on the knowledge and skills that they've gained through their participation in the program, and describe their plan for continued learning and involvement in leading clinical quality improvement. A capstone is intended to be a culminating moment or a crowning achievement, but as we've seen from our past cohorts, this day is just another step in a quality improvement journey for our CQIP grads. I would like to begin by honoring the lands that we are joining from this morning. I'm joining from Treaty 4 territory, but as we have attendees from all across the province, I would like to acknowledge that we are gathering on Treaty 2, 4, 5, 6, 8, and 10 territories and the homeland of the Métis Nation. Recognizing this history is important to our future and our efforts to close the gap in health outcomes between Indigenous and non-Indigenous peoples. I pay my respects to the traditional caretakers of this land. If you'd like to follow along with the program and project today, we have an electronic Capstone program booklet available for you to download from the HQC website. It has fillable fields, so you're welcome to use this document to add to your notes and reflections as we go through this program. Jocelyn will drop it in the chat now. Just a few housekeeping items to start. We would like to minimize the dialogue and distractions through the chat today, as we will move quickly through the talks, and we want to honor the individual presentations of each of our CQIP graduates. If you do have specific questions or reflections that come up during the presentations, there are a few ways that you can engage in today's conversation. If you have a specific question or reflection that come up for a CQIP presenter, you may send your question to HQC through the Q&A panel in the bottom right of your WebEx window. Please indicate who you would like to respond to your question, and Jocelyn will be sure to send that question to the presenter directly via email after today's event. Alternatively, we invite you to join the conversation that will be happening live on Twitter. You can follow Sherry Furness, CQIP Program Director, who will be live tweeting from the CQIP handle at CQIP_SK. Trust me, you don't want to miss her tweets. I encourage you to share your reactions, reflections, and questions using the hashtags #CQIP4 and #Capstone. Finally, if you have any WebEx tech questions that come up throughout the event, you can reach out to Jocelyn at the HQC by sending a direct message to the host account. Just a note, we are recording today's session so that you will be able to access recordings of all the opening remarks, quick talks, and the keynote address on the HQC website in coming weeks. So let's get underway. We are honored today to have several special guests with us providing opening remarks on behalf of CQIP's program partners. Sue Nimegeers. Sue is a patient partner from Radville, Saskatchewan, and has been a member of the CQIP Participant Selection Committee for the last 3 cohorts. Having served in various local QI initiatives in the SHA, Sue is no stranger to QI and change management. To her role on CQIP's Participant Selection Committee, Sue has brought a thoughtful and open-minded perspective on behalf of patients and families. We're thrilled Sue was able to join us this morning to kick off our opening remarks. Sue?
Thank you for that. I just want to welcome to all the 14 practicing physicians, 1 medical resident, 2 nurse practitioners, 2 pharmacists, and 1 pathologist assistant. First and foremost, I want to congratulate all 20 of the graduates of the CQIP Cohort 4 group. I am so honored to be able to personally congratulate you on your commitment to clinical quality improvement projects. It is truly something that you should all be very proud of. Although we will miss the opportunity to meet you all in person, we are still excited to be able to recognize your achievements, even virtually. This cohort all started back in 2019 which for some of us was just last fall. Earlier that year, in June of 2019, I had the privilege of being involved with the selection committee for Cohort 3 as well. We gathered in Saskatoon back in those good old days to celebrate those graduates like we are today. So I dug up some of my notes from that day, and there were two things that I wrote down that really resonated with me as a patient-family partner. The first one was, you only need to do two things every day, your work and improve your work. And the second thing I wrote down was that ideas are easy, change is hard. So at a time when almost everyone is exhausted and tired and probably lonely, it's very refreshing to meet with you all here today to celebrate and appreciate your care and all your successes. It is truly impressive as a patient-family partner to see your commitment to quality improvement and your passion to make the necessary changes and to keep learning. So I just want to leave you with a quick quote I found from a graduation ceremony in 2018. It was from the Stanford School of Medicine, where Dr. Paul Berg said, "Medicine is not for the faint-hearted, for it will engage every ounce of your powers of patience, understanding, and empathy. Aim high and keep learning." So congratulations, and please take the time today to pat yourselves on the back. Job well done.
Tracy Sharon is the Chief Executive Officer of the Health Quality Council. HQC, along its program partners, coordinates the delivery of CQIP. Welcome, Tracy.
Thank you and good morning. Welcome to everyone this morning. As an organization dedicated to accelerating improvement in health and healthcare in Saskatchewan, the Health Quality Council is thrilled to see that today we are adding 20 clinicians, including practicing physicians, medical residents, nurse practitioners, pharmacists, and a pathologist assistant to our community of clinical quality improvement program graduates, a community that is now 81 strong and growing. Continuing to build and grow this community of clinicians that are equipped to lead and facilitate quality improvement across Saskatchewan is vitally important to all peoples of this province. Now, I have to acknowledge that a program like this is the effort of many people and organizations, and I'd like to take a minute to acknowledge those who've helped to make Cohort 4 happen. We are very grateful to the Cohort faculty and coaches, many of whom are with us today, as well as program and project sponsors for your continued support and leadership in our learning community. And we hope to see you again in future cohorts. As you know, developing and delivering the clinical quality improvement program is a team effort, just like any improvement effort. We couldn't do this without our partners, our patient partners, the Saskatchewan Medical Association, the Ministry of Health, and the Saskatchewan Health Authority. Thank you to you for your support of this program. I also want to recognize our small but mighty HQC team and their efforts to provide a high-quality learning experience while demonstrating their commitment to continuous improvement and adapting to the many changes in our environment this year. Our health system has had a difficult year, and there are more challenges ahead. Despite all of that, we have come together to make significant accomplishments in responding to the COVID-19 pandemic. In all of this, I observed that the improvement skills and tools that you have learned in the Clinical Quality Improvement Program have played a significant role in planning and executing the response to the pandemic. I have also seen many of our CQIP community, including former participants and faculty and coaches, actively leading these efforts. While we still face challenges, what reassures me is that we have this community of clinicians that are dedicated to continuous quality improvement and who are using their skills to make a difference. And now all of you are part of it. I would encourage all of you to continue to contribute to the learning community by joining future cohorts as a faculty or a coach. As many of you know, Cohort 5 is scheduled to start in the spring. And I can guarantee you will learn just as much, if not more, than you did the first time around. I sincerely hope that each one of you will find ongoing opportunities to apply your quality improvement expertise in the communities where you live and work. I also encourage you to engage your circle of colleagues and coworkers in quality improvement activities in your communities. Optimizing the health of all people in Saskatchewan and optimizing quality of healthcare services are very worthy goals. I want to thank each of you for making a tangible commitment to these goals, and I wish you much success in your ongoing fulfillment of this commitment. Thank you.
Andrea McKay, as a Senior Analyst, Health Policy with the Saskatchewan Medical Association, Andrea has been involved with CQIP from the very beginning and brings greetings on behalf of the SMA.
Good morning, everyone. As Dr. Furry mentioned, I'm Andrea McKay, and I'm here to bring some opening remarks on behalf of the SMA. If anyone's familiar with SMA CEO Bonnie Richardson, you know that quality improvement courses through her veins, and she very much wanted to be here today to celebrate with everyone in this Capstone event to celebrate these physician leaders, but there was a conflict that took her away. So I'm here on her behalf. And as Dr. Furry mentioned, I have had the privilege of being involved in CQIP behind the scenes as a program partner since Cohort 1. And, in preparing these remarks, it's very amazing to me to reflect how, in Cohort 1, we went from anxiety that very few people would apply to, having trained over 80 physicians in clinical quality improvement skills. I think that's something to be commended. And as Tracy mentioned, these physicians are in turn paying it forward by participating as coaches and faculty in subsequent cohorts. So to me, that paints this kind of physician leadership snowball effect, and I think that's quite fitting for this January morning. And recently, this CQIP snowball effect reached the negotiation table with the SMA and the Ministry of Health, and resulted in $1 million per cohort of dedicated funding for CQIP and the 2017-22 negotiated agreement. And again, as someone who's been involved in CQIP from the beginning, having this dedicated funding is such a positive signal that our health system is committed to providing the right care at the right time through our physician leaders. So while this Capstone event obviously looks a bit different than most, I am looking forward to a wonderful morning, and congratulations to all the participants for all your hard work. I look forward to hearing your learnings and about your project. So thank you very much.
Denise Maxa, we're grateful to the Ministry of Health for their continued support and commitment to developing clinical QI leaders in Saskatchewan. Thank you to Denise Maxa, Associate Deputy Minister, for joining us this morning to bring remarks from the Ministry of Health.
Good morning, everyone. Thank you for inviting me to present opening remarks on behalf of the Ministry of Health and to graduates of Cohort 4 of the Clinical Quality Improvement Program. It's my first time at such an event, and I'm looking forward to it. The Ministry of Health's top priority is access to high-quality health care while ensuring our health system is sustainable. Improvement and innovation are key in ensuring appropriate care is provided. Through our partnership with the Health Quality Council, the Saskatchewan Medical Association, and the Saskatchewan Health Authority, we are better able to provide integrated services for the provinces. The Clinical Quality Improvement Program is an inclusive program that has welcomed practitioners from many vocations in healthcare to participate in quality improvement activities. As was noted, this is a very diverse group. A group of 20 clinicians will join a growing number of Clinical Quality Improvement Program graduates across Saskatchewan. Your hard work over the course of the past several months to complete projects and assignments for the Clinical Quality Improvement Program is greatly valued, especially with COVID-19 placing greater challenges on our healthcare system, and through that, your ongoing daily work. I look forward to seeing what you can achieve throughout your careers as improvement leaders in your fields of work, whether it's through leading and facilitating quality improvement in your place of work, serving as consultants for the quality improvement, or teaching to others. Your commitment to quality improvement is valuable to our healthcare system going forward. On behalf of the Ministry of Health, congratulations, and we can't wait to see what innovation and improvements you drive in the health system. Thank you.
To Anne Laurent, as the overall goal of CQIP is to build clinicians' capability to lead QI initiatives that result in better, safer care for patients, the Saskatchewan Health Authority is an instrumental CQIP partner. Welcome to Sue Anne Laurent, Chief Operating Officer in the SHA.
Thank you, Philip, and good morning, everyone. Thank you to each and every one of you for your dedication and passion you bring to clinical quality improvement in Saskatchewan's healthcare system. You've most definitely represented your professions proudly. The wide range of practitioners and clinicians is evidence of the innovation a program like this can bring to healthcare in our province. With the launch of the Saskatchewan Health Authority, we've been provided the privilege and the opportunity to better coordinate health services in our province and improve access to high-quality, timely patient care for Saskatchewan people. Under one integrated organization, each one of our more than 40,000 employees and 2,600 physicians are working together to achieve a single shared vision. A vision that sees our healthcare system that enables clinicians just like you to ensure that every patient, client, and resident can expect and will receive high-quality, timely care regardless of where they live. Together as one organization, we continue to confidently work to create a healthcare system that is better, smarter, safer, and more coordinated. The promise of a truly integrated healthcare system places a priority on building and leading improvement work with a focus on clinical quality improvement projects, just like all the ones that you guys have all graciously done. I want to assure you that the Saskatchewan Health Authority is as committed as you are to making our system better every day for patients, clients, residents, families, and providers at every interaction. We are committed to looking at where people are doing things right, and then achieving better care and improved outcomes, and then replicating those across our entire province. Much of what the Saskatchewan Health Authority works to emulate is reflective of the key elements of this program, including the use of data for continual improvement, leading teams, and facilitating and adapting to complex change. In these unprecedented times, the health system response to the COVID-19 pandemic has had to be immediate, nimble, agile, and malleable. Your education journey through this program would have mirrored our health system response. Anticipation and expectation of what this program is set up to do would have had to shift considerably to support the pandemic. The learnings and skills acquired through your partnership in the Clinical Quality Improvement Program are directly applicable to the current healthcare environment. Essential quality improvement work includes planning, developing new processes, looking at best evidence to implement something we are living at warp speed now on a daily basis. As you continue your leadership in quality improvement work, I encourage you to work collaboratively, not just with the people in this room, but also with the thousands of SHA staff and clinicians who are very dedicated to improving the health and well-being of our families, our friends, and our loved ones. I encourage you to continue pursuing system-wide initiatives that will both strengthen our healthcare system and provide a more consistent and coordinated approach to healthcare services across our entire province. I ask that you consider how, as one organization, we can better work with patients, families, clinicians, communities, and partners to co-design a system that provides people with a seamless care experience and addresses long-standing issues. The ability to learn and grow as individuals and as professionals is a special gift, and one we are capable to pass along to others. The knowledge and skills you have are very special, and sharing it with those around you makes for a very rewarding work environment, allowing us all really to grow together, to develop together in our quest to be the best at what we do. Together we're strong, much stronger. Using what you have acquired to CQIP in collaboration with other professionals across the province will help us not only to make the impact on the pandemic work today, but also healthcare work into the future. We are seeing innovations and initiatives developed in our response that will inform public health strategies and virtual care strategies. Seeing the integration of physician leadership includes the use of key metrics along with system-wide dashboards to make evidence-based decision-making and so much more. This work is leading to the real transformative change in our healthcare system. The pandemic has pushed us all to persevere beyond what we ever thought possible. And in working together and relying on one another, we have strengthened the bonds of who we are, one provincial team focused on the ultimate goal of the right care at the right time for everyone that we serve. Keeping patients, families, and all those that we serve at the center of everything we do is the foundation of the SHA in reaching our vision of healthy people and healthy Saskatchewan. It is truly because of the work you are doing here today and developing yourselves as QI leaders, contributing to the culture of improvement, that I know we will be successful as we continue to make our healthcare system better and safer every day. Thank you very much for letting me share this very special occasion with you. Congratulations on your achievements. Thanks for all the hard work that you do every day now in the SHA in these unprecedented times and always. Please stay safe, everyone, and thank you very much. Have a great day.
We will now move into the next section of our program, which is the participants' quick talk presentations. So just a few points on process. The quick talk format is exactly that, quick. Participants will have 3 minutes to project a brief overview of their project aim and implementation to date, as well as reflections on their learnings in the programs and where they would like to take their learnings next. Participants, you've been training for this through the entire program as you've honed your elevator pitches, so I expect you'll have no problem sticking to time. We are going to try and stick as closely as we can to this time limit. So participants, if you reach the 3-minute time limit, you will see an annotation arrow appear in the top right corner of your slide. That is your visual cue that you should be wrapping things up. I will introduce our first presenter, and then I will ask that the subsequent presenters introduce themselves and advance their own slides. When Jocelyn passes you the presenter ball, that is your cue to begin. You can turn your camera if you'd like, and then please unmute yourself to get started. A reminder that you can follow along in your Capstone program. Jocelyn will put that link again in the chat to see which speakers are coming up. So let's get started and kick off the quick talks with one of the 2 teams projects that we had in Cohort 4. Over to you and your team members, Dr. Adeyoye.
My name is Wale Adeyoye, and I'm joining this project by Amy Sabuski and Philip McGee. The title of our project is Reducing the Length of Stay at Saskatchewan's Psychiatric Rehabilitation Hospital. And background to this is that we met up to sort of identify a problem in the hospital. Sorry, I said we are based in North Battleford, and we all work in the Saskatchewan hospital. So we came together, we identified the problem that we can sort of make it an impact on and probably make a change in terms of quality. So we sort of identified that patients in the hospital, as well as the multidisciplinary team, do not consistently know when patients are going to be discharged and the process for the discharge. So in doing this, we went into the data set in the hospital and we focused on 2019. We identified the data set between January 1 and December 31st. And we sort of averaged the length of stay out. And as you can see, so the length of stay is 243 days. And we went into the literature as well to make comparison with that. And the background to this is that after identifying the problem, we wanted to sort of align this with the SHA strategic goal. And we came about with the goal for the project, which is to reduce unnecessary time spent in the hospital for patients and to improve the experiences of patients and the outcome relating to their discharge. And we also identified that it is good to improve on the discharge planning process and to connect a patient to care in the community. These are all in line with the SHA strategic goals. So we came up with our aim statement, which is by December 2020, there will be a 10% reduction in time from admission to discharge readiness for patients on West Peer Review A at the SAS Hospital in North Battleford. We identified West Peer Review A because that's the admission unit, and before patients when they become stabilized, that's when we transfer them to other units within the hospital. Before I hand over to Amy, some of the learning and reflection I've been able to get from the project is that, one, I think it's an opportunity to to be on the project and to learn on the project, to attend all the sessions that are provided. Learning process for me, and it's huge. And the other thing is that we started with a very broad aim statement, and it's taken us a lot of time to streamline this into one in order to get focus and to be able to make impact. We discovered that starting with a broad one, we are all over the place, and it was very difficult for us to make an impact on that. But getting coaching from all the sessions we attended was very helpful. And we had to amend our aim statement a number of times. I can't actually count the number of times we've done that. And the COVID-19 pandemic has impacted on our project in a lot of ways because we couldn't go ahead to further collect data. We had to sort of meet sporadically as well, and we had to sort of consider the safety of patients and safety of ourselves in our meeting as well. So these are all very they are good learning points for me. I will hand over to Amy Sabolsky now.
Thank you, Wally. So I'm Amy Sabolsky, and I'll talk about the next part of our project. When trying to really understand our problem, we went through many iterations of a root cause analysis and the driver diagrams. This was our final draft where we felt we really started to categorize the drivers for improvement and had a clearer sense of our possible change ideas. The change ideas that we focused on were to create a discharge readiness checklist and improve the discharge assessment process. We knew it would take a long time to have comparable data to measure the change in the length of stay for our ultimate outcome measure, so we focused on the process metrics and aimed that 100% of patients on the admission unit, West Prairie View A, would have an estimated discharge month by week 4 of admission, and that 100% of the MDRs would use a systematic checklist to facilitate structure and communication. We hypothesized that using the discharge readiness checklist and having a consistent weekly process of assessment would facilitate having an estimated and documented discharge month, which would improve seamless care and reduce inefficiencies in the discharge process, and then would hopefully over time reduce the length of stay. With these short-term targets in mind, we did many weekly Pdsa cycles to adjust our checklist content and structure, as well as the facilitation of the MDRs to clearly communicate and document the discharge assessment and the estimated discharge month. So the most significant learning piece I took away was to take time to really understand the problem instead of jumping to solutions. We had to approach the project with many questions and with an open mind, trusting the process and not skipping to our assumed conclusions. I was also reminded that change takes time and problems don't get fixed overnight. There are so many factors relating to psychiatric hospital length of stay, and many of them are related to external resources and out of our control. But we can make a difference by choosing one thing and focusing on one small change. There are many opportunities for future projects and research to address more of the internal and external factors related to psychiatric patient care. And finally, a team that includes many different ideas and opinions adds much strength to the project and opens up many possibilities. Thank you, and I'm going to pass it on to Phil.
Hello, my name is Phil McGee. I'm a nurse practitioner at Saskatchewan Hospital, and I just want to start off by thanking Amy and Wally for all the work they've done being part of the team. Now, one of the things that we did prior to the pandemic is that we really had two change theories in mind, pre and post. The reason being pre, we were like everyone else, trying to unfreeze and change and refreeze and using that Lewin theory where we had to pitch ideas and sell them. There was buy-in, was hesitant, change fatigue was happening at Saskatchewan Hospital. We had just moved in. We were under a lot of stress with other dynamics that we couldn't really reconcile. And like everybody else, we had multiple opinions and everybody wanting to add their opinion and wanting their idea to work. The pandemic hit and all of a sudden it seemed like Cotter's worked for us. There was a sense of urgency. Everyone was worried about patient safety as well as their own safety. All those barriers that seemed to have been present previously were somehow being moved. So we were really fortunate in some ways for the pandemic because it helped push our project. But there was other ways, of course, where we can all agree systemically it hasn't been great. Our short-term and our long-term decision goals got shorter and shorter, and we were starting to tackle shorter goals, which made it a little bit easier for us. So prior to the pandemic starting, we were using patient satisfaction surveys, impact questionnaires, we were getting in staff opinion, and we were trying to average the time of our multidisciplinary rounds. Reason being is that we started initially, it was 7-8 minutes a patient. When you're doing 24 patients a day, it can get longer, with our goal being 3-minute snapshots of being, what's your job, what's my job? Let's make sure when we reconvene that we've done our jobs. We've had to also change some of the vocabulary used at Saskatchewan Hospital because we were using terms that might have been outdated or that might have had multiple definitions. So we had to really streamline and make sure that we were able to speak the same language. This is what we've created, the discharge readiness checklist that we use at all our multidisciplinary reviews. It kind of gave everybody an idea of exactly what they are to talk about and what they can be expected to bring to the table, as well as it gives everyone the opportunity to know that this stuff will be talked about. So if there's anything that needs to be discussed, it can wait till the specific provider does their job. Like I said, fortunately versus unfortunately, the pandemic provided us a much needed catalyst. We are thankful that we had the idea implemented prior because we were able to start using this virtually. After the pandemic hit, a lot of these rounds went to WebEx like everything else. And once that hit, we felt that we had a flow in place. It was streamlined and everyone just knew what their job was. And as Amy mentioned and Wally mentioned, data collection might have stopped a little bit, but we look at imitation as a form of flattery. We started this on one specific unit, and it wasn't long before the rest of the units eventually picked up the idea and were like, how can we function without this? Some of my learning reflections are people buy in differently. It's amazing how one day somebody buys in and the next day they don't, or what really triggers somebody. You know, is it personal gain? Is it financial gain? Is it patient gain? There's so many reasons why. So that was one of the big learning opportunities for me. A problem for you is not necessarily a problem for me. So the same reason why the buy-in, what bothers you today might not bother me, and it might not be a priority. So it was trying to learn what everybody's priorities were and trying to work within them. And I'd like to end on this is that quality improvement is like a box of chocolates. You never know what you're going to get, but essentially, we're all trying to finish the box of chocolates. Whether you like the cherry one and I like the truffle, the goal at the end of the day is that we eat all the chocolates. So our QI project was simply a box of chocolates that we all shared together. And in closing, we'd like to thank the following people that have helped us: the staff and clinical care team on the West Prairie View A units and throughout Saskatchewan Hospital, Randy Lindquist, the manager, Joe Galloway, our patient advisor and family advisor, Randy Bird, our Indigenous patient advisor, Monica Yohanhan, our quality improvement officer in the Battlefords, Linda Shankirk and Dr. Duncan, who are our sponsors, as well as the Saskatchewan Health Quality Council and the Saskatchewan Health Authority. Thank you kindly for the opportunity to present today.
All right. So I'm Hannah Buhariwala, and I looked at patient communication at discharge. So discharge from hospital is one of the most dangerous times for patients, and my QI team was made up of inpatient and outpatient providers, as well as some patient family advisors. So together we decided that the biggest issue with hospital discharge was communication with patients around discharge plans and discharge medications. The Society of Hospital Medicine has named 7 elements for communication to patients that are considered required for optimal discharge. So my aim statement is that by July 2021, 100% of the patients discharged home from our unit will be provided with all of the crucial elements required for safe discharge, both verbally and in writing. Major themes that lead to poor quality discharge instructions include lack of standardized expectations for providers, provider beliefs, and provider availability or time constraints. So this is my driver diagram, as well as my change ideas, but in the interest of a 3-minute presentation, I'll highlight 2 of the primary drivers. The current discharge communication tools for patients are essentially a blank form, so they're entirely provider dependent, and redesigning our standardized communication tools directly affected a number of our secondary drivers. So this is where our QI team decided to focus our efforts. Unfortunately, the hospital culture is that nobody really wants to own overwhelmingly complex problems, and everyone assumes that what's not being done by them is being done by other people. A rough process map showed that unfortunately this isn't the case, so there's a lot of room for improvement. When I did a chart audit for patients who had been discharged home, none of the discharge instructions contained all 6 crucial elements for optimal discharge. And actually 10% had no discharge information provided at all. And items that were the most often omitted included discharge medications and return to care instructions. So a survey went out to the accountable care unit hospitalists and patient family advisors. And interestingly, both groups thought the communication about discharge medications and return to care instructions were crucial pieces of information. And remember that these were the 2 elements most frequently missing in the audited charts. Most PFAs felt that instructions should be provided verbally and in writing, while 50% of hospitalists felt that one or the other would be fine. And most hospitalists believed that community pharmacists should be the ones to review all medication changes, whereas only 20% of PFAs, based on experience, considered their community pharmacists to be a good resource to explain changes made in hospital. So now we're piloting a discharge communication form on 4A, and it's been designed to include all 6 crucial elements required for optimal discharge, and it also includes a patient-friendly MedRec. So once we've worked out the kinks in our new form, we plan to expand this to other units. We would like to get to a place where we can begin the discharge process 3 days before discharge and involve more members of the interdisciplinary team in completing and reviewing the form with patients before they're discharged. We're doing ongoing chart audits, and we'll have data for 7 and 30-day readmissions from before, during, and after implementation of our tools for future run charts. And future plans include development of an interdisciplinary discharge checklist and a post-discharge phone call to patients. So on our ACUs, we provide standardized care delivered by the interdisciplinary team, but discharges are very complicated. So thank you very much to the CQIP team for giving me the tools to get organized, dig into the problem, and actually start to improve the quality of our discharges.
Good morning, everyone. My name is Stéphane Duchesne, and I'm a pathology assistant for the histology department at POSCO Hospital in Regina. The title of my project is Optimizing Mastectomy and Excisional Biopsy Handling Procedures for Optimal Histologic Examination. My aim statement is, by spring 2020, the PH and RGH pathology laboratory will optimize compliance with extant guidelines with respect to handling, dissection, and tissue processing of mastectomy and breast excisional biopsy specimens to reflect high-quality patient care. In late 2018, we started noticing requisition discrepancies and specimen integrity issues received from our own ORs and some of the peripheral hospitals. We started to collect data to classify the type of discrepancies occurring and where they originated. Based on that, we felt it necessary to provide a refresher information session so that the staff involved in the pre-analytic phase understood the importance of proper specimen handling. Essentially, we were in Pdsa without even knowing it. In September 2019, Cohort 4 began, and we tailored our existing data collection and information session to focus on breast specimens, as they seem to be the ones with the most issues. The proper handling of breast specimens helps us determine the biomarker status of breast cancer patient, and that information helps us to identify those patients who could benefit from hormonal therapy and monoclonal antibody therapy. The College of American Pathologists recommends that breast lesions be exposed to tissue fixative within 60 minutes of the excision time. Delays in fixation and to some extent overfixation have been attributed to false negative biomarker status, which could potentially result in patients receiving the incorrect or not receiving the correct treatment. The primary drivers for this research include current CAP guidelines, maintenance of CAP laboratory accreditation, best practice literature, and the number of recurrence reports related to ischemic times and specimen integrity. In September and November of 2019, we again delivered information sessions to OR nurses at POSCO and RGH, as they are the first team of people directly responsible for mastectomy specimen handling. These sessions address fixation with formalin, how and why biomarker testing is performed, and we addressed some of the discrepancies we had identified once the specimen was received in our lab. During this time period, we continued to collect data using a REDCap tool, data from our requisitions. The optimized dissection phase and optimized tissue processing phase of this project are still ongoing, so please stay tuned. Overall, we evaluated 191 breast specimens, and we found that 35% of specimens had at least one discrepancy, ranging from 1 to 3 issues per specimen. ischemic time guidelines not met, and information missing from the requisition were the most prevalent issues, occurring 35 times and 24 times. When we evaluated the data by number of issues, we saw that 32% of the specimens received had at least one discrepancy. We also found that 64% of peripheral hospitals had also at least one discrepancy. At the Pasco Hospital, the total formalin exposure time had a median of 67 hours, and at the RGH, a median of 31 hours, and CAP guidelines suggest 72 hours of maximum fixation. Some of the key learnings, quality does take time and we have to expect the unexpected. It's important to engage and involve stakeholders early. And lastly, laboratory medicine I find is often misunderstood by a lot of clinicians, and then many people don't realize all the steps and people involved in generating accurate results. Thank you.
Good morning. I'm Shazia Durrani, a geriatric psychiatrist based in Regina. My project aim was to improve the detection and management of delirium in elderly patients by 50% in an accountable care unit in Pasco Hospital, Regina. I have to say, even though we managed to achieve our aim, our ongoing work needs to be done to sustain this change. I work with other team members and see a lot of elderly patients in long-term care facilities. We noticed that many patients were discharged from acute hospital after a period of brief illness with ongoing antipsychotic treatment, yet they had no known psychiatric disorder other than dementia. We figured the likely cause was delirium. We therefore focused on assessment and management of delirium in elderly patients and worked with an accountable care unit. We created evidence-based order set and links to a treatment algorithm and assessment tools. We used driver diagrams and fishbone analysis to find the contributing factors. We provided education to staff and information to patients and family members. We completed 2 Pdsa cycles, and following that, had the opportunity to get our order set and assessment tools approved for use across the hospital and long-term care facilities in Regina. Our first Pdsa cycle was for 5 weeks. The staff completed confusion assessment method tools on every patient in each shift. This obviously led to completing a lot of CAM tools. Hence, the unit manager had to provide follow-up. The positive tools were then discussed in the daily rounds, and the physician could then use the order set and algorithm as well as patient education. In our second Pdsa cycle, we simplified the process by modifying the nurse's daily review chart. We included change from baseline as part of their mental status examination, and the change in baseline would then trigger the nurse to use the CAM tool, which she could then present at the daily ward rounds for the physician to use the order set and the algorithm. These are the total number of CAMs used on weekly basis across the 2 Pdsa cycles. As you can notice, a lot more CAMs were done in the first cycle as compared to the second one. These are the total number of order sets or PPOs used on weekly basis in the accountable care unit for delirium. And this is a similar graphic presentation for the same process. We had staff feedback at the end of this process. The strengths were identified as early detection with standardized approach. It improved staff awareness and reduced the pharmacological interventions, as well as some staff felt it helped with early discharges. The barriers were the fact that the medication dosing schedule in the order set was somewhat confusing, and staff would prefer a scheduled dosing rather than PRN at the start. Everyone agreed that the use of CAM and PPO should expand to all other units, but further training should be provided, which is what we did. Staff training modules were provided, and physician education videos were prepared and provided across the intranet. From this process, I learned some key factors. I learned that it is important to listen to people on the ground to make a lasting change. A lot of time and patience is needed when we want to make a change that includes change in practice as well as working culture. In our project, we had input from the departments of psychiatry, continuing care, and hospitalist unit. And by working together, from these three departments, we managed to achieve our goal. Therefore, teamwork is key. We had the support from my sponsors, my coach, the CQIP process helped us guide, and that gives us the privilege to work on this project. So on behalf of my CQIP team, I thank you all.
Yeah. Hello. Hi, good morning, everyone. I'm Amanda Elwood, and I work with Dr. Ron Taylor. Can everyone hear me?
Yes, we can.
Yeah, perfect. Thank you. Okay, sorry, we're just having a little bit of trouble loading our slides here. And our project looks at discharge prescription from discharge from hospital and medication reconciliation. Okay, so in terms of the background, as you can see, medication at discharge it can be a major problem, and it can lead to significant adverse drug events and potential harm to patients. Our aim statement originally was to have every patient discharged from the Pasco Hospital ACU have an accurately reconciled discharge prescription that is shared with the patient, their community pharmacists, and community care providers. Our updated aim statement was to look at reducing medication discrepancy at discharge by 50% on 4B and return to the community by September 1st, 2021. So this is a slide of our aim, our driver diagram. So as you can see, our primary drivers, there are four main primary drivers, including communication, discharge prescription process, medication tracking, and practitioner time. I'm going to focus mainly on the first primary driver, communication, which led to our secondary drivers and change ideas. So initially there's no standardization or form for discharge prescription. So a standardized medication reconciled discharge prescription was developed and used. There were also transcription errors, and there were also difficulties with illegible handwriting. So printing this form off helped to alleviate some of those problems. There are also issues with the form being filled out correctly. So one change idea was to educate nurses, physicians, pharmacists, and unit clerks on how to fill out the form and who to send the form to. There is sometimes some difficulty between congruence of the discharge prescription and the discharge summary. So a change idea was to help track accuracy of completion of the form at admission and discharge, and then provide feedback to the team. Another change idea was auditing, comparing discharge prescription with the discharge summary. Another secondary driver was looking at a coordination of providers between inpatient and outpatient. So a change idea was to follow up with the pharmacy for feedback from the discharge prescription and to stamp the discharge prescription with the unit contact number. So if the pharmacy had questions, they could call back to that unit. And also giving a patient a copy of the discharge prescription as well. In terms of key learnings and reflections, I felt that my key learnings and reflections related to the aim statement. Initially, we had a very wide aim statement, and we had difficulty narrowing it down to an achievable project. Eventually, we managed to narrow it down to something that we could achieve. We started off with the solution, and rather than looking at the problem, and it took us several adjustments of that aim statement to find a narrow enough statement that we could achieve. And that was what I found very memorable. And on to you, Dr. Taylor.
All right. Thank you, Dr. Elwood. So I'm going to pick up with some of the information that we picked up through our process. And the first thing was auditing the actual discharge form, where we did find that the form is being used 96 to 100% of the time. So that was a success. However, as you can see, the administration of the form was suboptimal, and there was lots of gaps. And there was still at least one discrepancy on at least 70% of the charts that were audited, and so the form itself wasn't the answer by itself. We also did a survey of the receiving end of the discharge prescription, the community pharmacists, and the win was the form helped them better understand and fill the discharge prescription, and they felt like it decreased their work. But at the same time, they were still phoning back to the hospital at a high rate to clarify the discharge prescription. And they also noticed recurrent errors. There was an opportunity to see if we could theme these and do better. And then I think another big win was the degree of engagement in some of the community pharmacists for partnering to keep working on this process. Our next steps, we are in the process of providing better education about the use of the form, not just to the physicians, but to the entire care team on the accountable care unit, so that we are filling the gaps with the administrative errors, and we're going to do a prospective audit and feedback to the group so that they get some information around their performance. We are beginning a process of process mapping for all the contributors to this team-based approach to make sure that we get a decrease in the discrepancies over time, and we'll be tracking that going forward. And then finally, it's apparent to us working on the ACUs, Dr. Bahariwala earlier and Dr. Cuddington coming up for the next cohort, that the ideas that we've been working on independently probably merge together, and we'll be looking at creating some synergy between our ideas and our process. Personally, for me, about learnings and reflections, I have sort of three buckets. One is the biggest chunk of learning had to do with knowledge around run and control charts and QI data, and passing this along, although it didn't manifest in this presentation, to the other work we do on ACUs and sharing how to look at our units with nursing leadership, nursing educators, pharmacists, and even our patient family advisors. I think this journey has reinforced the opportunity of accountable care units with the team that's already in place, the structure and process we have to make it truly a continuous improvement environment. And then finally, my most positive reflection is the way things are building up at the Pasco Hospital with Dr. McNee having done the CQIP program, and then Dr. Pepler, and in this cohort, myself with Dr. Elwood and Dr. Bahariwala, Dr. McDonald, and then going forward, Dr. Liskowich and Dr. Cuddington, and how we're all learning to see the system in a similar improvement vein.
Good morning, everyone. My name is Dr. Andrea Fong. I'm a pediatric allergist and clinical immunologist based in Regina. My CQIP project will discuss the use of food allergy screening panels in Saskatchewan. In 2016, Choosing Wisely Canada included food allergy screening panels as one of the tests that patients and healthcare providers should question before ordering. Their recommendation states, don't perform screening panels, that is IgE tests for food allergies, without previous consideration of the pertinent medical history. So what are food allergy screening panels? When someone develops a food allergy, their body produces IgE antibodies directed against the food that they are allergic to. Food allergy screening panels test for specific IgE antibodies to multiple foods at the same time and unfortunately have a high rate of false positives. Without a convincing clinical history, the false positive rate can be as high as 75%. So the goal of my project was to reduce the number of screening panels for food allergies ordered in this province by 90% by December 31st, 2020. In my driver diagram, we identified the following primary drivers, and we'll go through one of them today. So for the primary driver of order process, we identified physician knowledge and selection of tests as secondary drivers and came up with the following change ideas. At this time, we are discussing education sessions for areas with high rates of ordering screening panels, education handouts like flowcharts for clinics regarding the proper indications for allergy testing, potentially changing the lab requisition itself so that physicians must specify what food-specific IgE levels they are ordering. Currently, it's just a tick box, and once you just check off that box, it orders 5 different food allergy tests at the same time, and potentially removing the test. So where are we in terms of implementation and results? Currently, we've met with our PFAs. The bulk of our work still is in the process of collecting data. As something that we did find out, in 2019, about 2,000 of these food allergy screening panels were ordered in the province at a cost of approximately $280,000. The challenges that we encountered included who we would reach out to get the data that we even needed. Once we got the data, we found that there was some discrepancies in terms of the ordering physician. So just even getting the correct data was a challenge, and of course the delays due to the current pandemic. So my key learnings and reflections reflect a lot of what my cohort participants have already mentioned. I certainly went into this project just leading with the solution of we just need to remove this test. But I really appreciated the learning process of looking into root causes and always asking why. I am also someone who thought that it would be very easy to make this change, and I've learned that change takes a lot of time at the best of times, even when we're not in a pandemic, and certainly this past year has tested that as well. I also came into this project just as an individual, and I'm walking out with a team of people who are helping me. And that has was something I didn't expect, that I would leave this project with more people on my team to help me for this project, as even with the end of CQIP, I am definitely planning to see this project through. And with that, I would like to acknowledge the organizers, coaches, and my fellow participants for all the learning that was provided this past year. My coach, Dr. Christine Lett, Michelle Dagelman, who has helped immensely with my data, and of course, the invaluable input from my PFAs. Thank you.
Good morning. I am Andre Haribor. I'm one of the neonatologists at the General, and the project for the cohort was about trying to optimize blood work in the NICU, as it seemed that there was significant variation to other, places of practice, and even between days and practitioners and all of that, and we had reasonable thoughts about the fact that could result into maybe less blood work in general, less pokes, and potentially a little savings. And the main aim was that the number of tests and blood sampling episodes could be reduced by at least 10% when looking at it as a whole to the total number of tests performed per patient in the NICU. And this could be achieved without decreasing safety, which it means that we won't miss something that we should have caught with a blood test. So obviously, some thought was put into, well, what is this blood work about? And it's about many things, right? It's about ordering it, it's about lab processes, and it's about, patterns of care, which are different from place to place, and even from, depending on the density of providers, even between weekend and the regular week, and so on and so forth. So there are a number of factors, obviously, that play into this, and a few of them were reasonably approachable to everybody who came together in the team to do this. So we ended up with what looked like a beautiful team with representatives from the orders, and then the nursing and the lab, PFA, who was fantastic, and it seemed like the consensus was fairly easy to achieve on the core principles, and a few ways to go forward. And then there's obviously a big piece of lab to this, and that worked well for a while. And eventually everybody agreed what we were going to do in our first cycle. And then there was a fair amount of work and gather the data about all the testing in NICU over the previous 3 years and preparing, doing a lot of manual data cleaning up and sorting out so we can do some run charts and all of that. And, our lab counterpart was very sweet and we went through. So this is an example of a standard and a trend one. And you'll see that. So the one this is it's the lights, and this is renal panels, and then it should have moved. But then what happened was there was really extraordinary turnover in the division, and 3 out of the 5 consultants disappeared, and new came in, and a number of our clinical also came in. The maternal child director and the unit manager changed as well. It was just this extraordinary personnel change, and of course, everybody was overwhelmed with COVID, and the lab was one of the key areas. So we are just going back to it right now, and trying to move into a first cycle and take it from there. So, I mean, the key learnings would be that really improvement it's all about the mindset, and the mindset is that it's a biological thing. Life is change, and change can be accepted and controlled collectively, and if it is, it becomes improvement, and if it isn't, well, it's just change. And then the other piece is that everybody in the community has to really be with it, otherwise it doesn't work. And that's, well, just like this COVID, obstacles will come and go. We just have to. If we have it in our heart, we will see the end of it, and that's really cool. And I obviously want to say that this has been an absolute blast, and I've enjoyed every second of it, and I'm very thankful to the faculty as well as to our peers and co-cohorters. It has been fantastic. Thank you very much.
So I would like to thank our first half of our CQIP participants that presented for us. You can see with the presentations that there's quite a lot of hard work that went into these presentations, and the thing that gets me all excited is looking at the potential for quality improvement in the system. So with that, we would like to break for 10 minutes or so. We will be resuming at 9:15. So it'll give you some time just for a biological break. And at 9:15, we would like to be back here, and then we'll resume our second half of the participants. See you in 10 minutes. It's 9:15, and we are going to be resuming our second half of our quick talks. In this group, we have 8 presenters, and we're going to kick things off with Kyle Mcdonald. Kyle, over to you.
Thanks so much. So my name is Kyle. I'm one of the family doctor hospitalists at the Pasqua, and my project was looking at opioid prescribing practices at the Pasqua Hospital. And I think like most of us, I started out, you sort of see at the bottom of the slide, my original aim statement that I went into CQIP about was all about trying to reduce IV opioids. Because in my mind, if we could stop using IV opioids so much, we would be able to solve the opioid epidemic. And I got linked in with some really good people, and I started working with the opioid stewardship team actually over at the General Hospital. And eventually the revised aim statement after a couple of PDSAs and a couple of cycles of improvement changed to just being able to get some baseline data, measure the appropriateness of opioid use at the Pasqua, and then hopefully feed this information back to the doctors on the accountable care units and see if it would improve the appropriateness of opioid prescribing. We were hoping to have this done and have Pdsa cycle go through, and then COVID happened. So it's still on hold, but at least I have some baseline data, which I'm excited to show. One of the other big pieces that I also really liked about going through this process was I ended up meeting a lot of like-minded people. And this is a driver diagram that Sarah Todd, she's one of the nurses over at the Pasqua, and she's a site manager, helped me to develop. And this is just all about trying to reduce opioid use in general. And you can sort of see, if you follow down to care providers, the secondary drivers would be to potentially modify opioid prescribing practices. So definitely only tackling IV opioid use would, of course, only tackle a very, very small percentage or problem of the bigger opioid problem that I think we're facing. So going through this process led me to realize that you shouldn't lead with your solution, and helped me make some really cool connections. Some of our initial results were looking at pre-admission opioids. We saw that the majority of patients actually came in with no opioids, and then the second most common was hydromorphone. One of the neat things is, out of the 7 physicians we surveyed, the red line shows the morphine equivalent, so anything less than that is actually appropriate. So overall, we're actually doing pretty good, and there seems to be just this one provider that got dragged sort of higher for a number of reasons, but overall, we were doing pretty good with opioid prescribing. One of the other key factors we looked at was whether or not we used the oral route versus IV or sub-Q, or another route entirely. And the chart on the left is a logarithmic scale, so you can see that the oral route almost has 2,000 orders wrote, versus the IV medication route was only 190, which was a good learning point for me as well. And one of the other pieces of data we were able to obtain with the team we assembled was just all about discharge length and how often we prescribe opioids on discharge. Most of the time we don't, which is good to see. But then an interesting piece for me was actually when we do prescribe opioids for discharge, we're usually prescribing them for greater than 7 days, which a lot of the guidelines suggest we shouldn't be doing. So my key takeaways from this project were, don't lead with your solution, which was a huge one for me, because if we would have only focused on IV opioids, we would have only caught 9% of all opioid prescriptions out of, well, obviously all the other opioid prescriptions, but when you look back to that driver diagram, we would have seen I would have been only tackling a very small portion of the problem. And just going through the process made me realize that there's way more to this than we think. The other cool part was developing that team was definitely essential. So I worked with the opioid stewardship department, which had some amazing people in it, Sarah Todd, and we got to go through that process map process with her. And then I was actually able to work on a Suboxone and opioid withdrawal PPO with some of the other colleagues I met, which was very cool. And then my last piece was just opioid prescribing is complex, and it has lots of moving pieces. But right now we actually have some pretty good baseline data that I'm hopeful we can start using for future PDSAs and comparing to the baseline data. And I think the next step in my mind would be trying to tackle those discharge prescription lengths, which I hope to try and do after COVID. So it was a good journey, and I appreciate it.
Hi, everyone. My name is Jonathan. My project was to look at blood glucose control for our cardiac surgery patients here in Regina General. Jumping in directly, skipping over the left of the background here, we were focusing on trying to maintain euglycemia for our cardiac surgery patients. We know from the available evidence that if patients became hyperglycemic, it increased their risk of a lot of things, including death ultimately, but also a lot of comorbidities and a few other issues that went along with things. So our aim was to try and maintain this euglycemia for at least 48 hours post-op, post-cardiac surgery. Driving in through this and looking at, of course, there's many layers and many things that delve into this. And, as a East Coast kid that I am, learning things like something called a fish bone could be useful for something more than fertilizer was lovely. And driving these things forward to then build up some of the ideas we had for some of the changes to go about. I actually came into this a little bit earlier, and as Stephanie mentioned earlier, we were in a Pdsa cycle without realizing it early on. If you go back to look, we started our baseline data collection back actually in December 2017, going through essentially 3 Pdsa cycles to describe. The first one was post-operative surgery. We decided we would continue to run the insulin infusions that is normally kept on while the patient is intubated, even when they're extubated, to help maintain better glycemic control. That was the intent. Pdsa number 2 was started in September 2019, which was to bring in, a decision support tool for the transition of this IV infusion over to subcutaneous basal bolus. And then finally, just before the pandemic hit, we changed the availability of insulins in the critical care area to try and increase that or modify that transition. So initially, our background, our baseline data, each one of those colored lines is an individual patient, so you can see there's lots of variation and B, lots and lots of data to play with. That red solid line is that 10 millimoles of blood glucose in the serum that we were trying to target to keep everyone below. More simply, after we did a little bit of with some support from the data scientists doing some modeling to go with it, again, on the vertical axis, you see blood glucose. On the horizontal axis, you'll see time post-procedure, so post-OR. And then the gray thin lines in the background are individual patients. That red solid line, again, is that 10 millimoles of blood glucose we were trying to keep people below. You see at baseline, there's quite a bit of variability. And on average, the red line there, or sorry, the blue line there, patients were still getting up above 10 millimoles early on within the first day, but actually in the second day, they were doing, things seemed to be dropping down below that line quite well. After we decided to continue to run the infusion for the first, until 8 a.m. the next morning, we can see that actually in the first day, we were managing to get on average, the blood glucose down below that 10. As you can see with the background there's quite a bit of variation still. And in the second day, that's when we were having patients sort of drift up above. Pdsa cycle 2, which was again to bring in a decision support tool to try and get the blood glucose in better control. In the second day, you can see still quite a bit of variation, but on average, patients were below that line. Finally, in our third iteration, where we then change the availability of some of the insulins in critical care to try and bring that down. Again, still not quite there. There's still quite a bit of variation, but for the most part, we're getting 60 to 80% of our patients to maintain their blood glucose below the 10 millimoles that we're aiming for. So next steps, we're in the midst of a surge, as everyone is aware, and so one thing we want to look at is some of the use and some utilization of that decision support tool in feedback and talking directly with clinicians, including myself. Sometimes that tool suggests we use large doses of insulin, and that scares us. Scares me too. And so our question is how we're doing, how we're maintaining and utilizing the tool that's available to us. And if it's not there, is it a concern with the tool itself, or is it a concern with collecting and showing that it is actually a safe option, that we are underdosing and we're actually not putting our patients at risk by using the high dose that it might be suggesting. The next thing that we're also considering is what the glucose pre-op was, how their patient's control was before they went to the OR. And then finally, there's some question about the testing frequency, post-update 2. Key learning for me was the target markers of choice. And as you saw, there was a massive data. So talking to data scientists, maybe we need to think about what markers we're using and how often we're sampling. I personally got hung up on some of the smaller details, and thankfully, that slowed us down a little bit, but thankfully my team was able to help support and sort of spread that out a little bit. And as well, I think the biggest thing for me was to try and engage that team a little bit sooner and get everyone in a room a little bit sooner to ask some of those questions. I have lots of people to thank, the data scientists, Ange Payne and Meredith Ferris, who did a lot of the unfreezing for me, which was great, as well as my sponsor, my coach, and the rest of the team here. Thanks very much.
Hi, my name is Ayla Moeen, and I'm a family physician in Saskatoon. My project was to improve HIV preventive care at Student Wellness Center, University of Saskatchewan. Prior to 2019, we were not providing the service at all at our clinic. And our aim was that by May 2020, we would increase the number of students being assessed for preventive treatment to 30. We identified 4 possible intervention areas to achieve this. We needed a prescription process, we needed to make sure there was enough student demand for it, and we needed to increase referrals from both within the clinic and outside it. We started off by increasing the comfort level of family physicians in order to become prescribers. We have 7 physicians working at our clinic, and out of those, 3 are willing to prescribe. Next, we turned to referrals from nurses. At the end of the study period, 35% of the patients who had presented to our clinic for STI screening had been offered assessment by the nurses. And out of those, 75% ended up being assessed. We then turned to the students to get a better understanding of what their needs were. We held a focus group in March 2020, and we all know what happened. A week later, the university was closed, unfortunately, because of the pandemic. So if you remember the magic number from my second slide, which was our aim statement, so far we have seen 15 students for preventive treatment. So we reached 50% of our target. This is what our journey has been like to reach those 15. It's slowish, but steady. So my key learnings from this project were based on some of the challenges that I faced. First and foremost, I realized how important it is to have data. We started this project without any, and it was kind of like flying blind. We didn't know if we were aiming too high, too low, or just about right. Next, it's really important to engage everyone possible to get different perspectives on the table. And most of all, in preventive care, it's very important to engage students. And finally, as we've heard before, preventive care must go on in face of pandemic or other crisis. So where are we going from here? We're taking a little bit of a detour and doing a research project that came from this QI project. We're doing a student survey to find out more about the attitudes of students about preventive treatment and identifying barriers to access. We'll head back to our PDSAs involving increasing referrals from our counselors within the clinic as well as from family physicians within the community. I would like to thank all the CQIP faculty, my coach, my sponsor, my PFA, and my data analyst from SHA, and last but not the least, all my fellow participants for their feedback and encouragement that made this project possible. Thank you.
All right, so I'm Ray Petruka. I'm a family doctor in Saskatoon, and I work out of Westwinds Primary Health Center, which is the site for our academic family medicine program, where we teach family medicine residents in Saskatoon. My project is looking at improving access to care for vulnerable older adult patients residing in personal care homes. And a little bit of the background for this project was that when I first started looking at it, I have 6 personal care homes that I have been rounding at since I started practice about 6.5 years ago. The patients who live in these homes tend to be quite elderly, very frail, unable to come into clinic for assessment or management. And so I was looking at a way to streamline some of the communication between patients, the caregivers in the personal care homes, and their families with myself and the clinic, because it was a bit of a disaster when we started. So my aim statement was that by April of 2020, all communication regarding personal care home patients will receive a response from the clinic on the same day. My initial driver diagram, I did not have the right questions asked. And then after our workshop session with Brandon, it clarified very nicely. And so this was the area that we actually looked at making adjustments with. So for implementation, what we ended up doing was we co-created a modified SBAR communication tool with the RN in our clinic, as well as several of the care home staff and myself. And then again, with our Nurse Bethany, we modified the clinic process for phone calls received regarding these patients to streamline it within the clinic. So our first Pdsa cycle was done in February 3rd of 2020, where we had the SBAR tool ready to go. We started using it as well as a new clinic process for triaging the phone calls. And immediately I stopped getting phone calls and texts regarding these patients to my personal cell phone, which was amazing. And we stopped getting pharmacy receiving those phone calls within about 2 weeks, which they were very happy about. The second Pdsa cycle that we started was done on October 5th of last year, and that was to increase the involvement of the family medicine residents in care for these patients to improve continuity. So some initial results. When we first started the project, about 59% of contact was actually going to the clinic instead of to my personal cell phone. And when we started using the SBAR tool in the new clinic process, it immediately went to 100%, which was fantastic. The community pharmacy was really happy because after 2 weeks, they stopped getting those phone calls and then they didn't have to be a middleman. And I received a lot of positive feedback from patients, their families, and the caregivers at the care home about the involvement of the family medicine residents, which is also nice. The big things that I learned and reflected on during this project are that we needed to do more training and supporting of the care home staff in using that communication tool that we generated with them. There's almost always another level to go down to when working to identify the real processes causing problems. So like just continually asking why and then running with the answer that you get, even if it's not what you expect. And then also realizing how many other areas there are for quality improvement work in this patient population that's possible, so that hopefully this type of work is more manageable for community physicians.
Good morning. Thank you very much. My name is Dr. Bonnie Richardson. I'm speaking from Regina today. I'm an internal medicine doctor, a nephrologist, the ADL Department of Medicine here in Regina, and I'm acting in the current capacity of IHIC co-defense chief for the pandemic physician at Lead. So thank you. So my CQIP project revolved around optimizing anemia in hospitalized patients that are on hemodialysis. So I'll show you my aim statement, and while you're reading my aim statement, which is pretty short, which was a really good learning opportunity for me to really drill that down and see what the actual problem was, I'll tell you a little bit about the way of the background. So what we have on a typical patient comes in very ill, very sick, potentially flown in from STARS, emergency situation, and they're admitted to our intensive care unit. We're worried about cardiogenic shock, septic shock. Often these patients are very ill, intubated, ventilated, on medications to keep blood pressure and cardiac output optimized. So we're very focused when the patient's this ill on optimizing their heart, their multi-organ failure. They're often on continuous renal replacement therapy, which is a type of dialysis that runs 24 hours a day, and managing their electrolytes and their acid base. What happens over time, for multiple reasons, is the hemoglobin, which carries oxygen, trickles down. One of these reasons is just that the patients are very, very sick. Another reason is, of course, we're doing frequent blood tests. But a little unknown fact about the kidney is it actually sends the hormonal message over to the bone marrow to make blood cells. So if your kidney's not working, you're not going to be producing the blood cells. The hemoglobin tends to drift down and down and down in these sick ICU patients, even after we get them stabilized, because we're focused on everything else, sometimes we don't notice as a team of care providers until that hemoglobin hits this magic number of 70, which means, wow, we need to transfuse. Transfusion is not ideal for any patient. There's numerous side effects and risk to patients giving blood transfusions. Additionally, it's a significant strain on our system cost-wise, but importantly for our kidney patients, if they don't recover from their acute kidney injury requiring dialysis and they go on a transplant, if we've given them blood products, they build up antibodies and they're less apt to receive a transplant in the future. So it's a really big deal for us to identify these patients early on, because there's medications and hormones that we can give to help replace the transfusion. So, and originally when I was looking at this, I was thinking, we just need to be, giving these patients these medications and optimizing them earlier. But really, I think one of the take-homes from this project, I kept hearing, what is the problem? What is the problem? We all want to do the right thing. The ICU, the nurses, the nephrologists, the intensivists. I think what the issue is when we really drilled down for the AIM statement, which was revamped a few different times, was identifying the patients. So really what the problem is not that they're anemic, it's identifying them earlier on when to intervene. So the AIM statement became, in June 2021, 100% of hemodialysis patients in hospital will be identified early and started on anemia management. So another learning tool for me was the driver diagram. I learned a lot kind of going through these and the fish diagrams and looking at the primary and secondary drivers around optimizing care in these patients. And it's really involving a lot of people and a lot of opportunities in the system and identifying those gaps. We all want to create a culture of safety and quality. We want to improve communication between, the kidney doctor and the ICU team, and we want to be looking at who are the stakeholders in these processes. We've got nurses, we've got pharmacists to help us manage these things. We have our nephrologists, which is our kidney docs, our charge nurse, our hemodialysis charge nurse, our ICU charge nurse. Lots and lots of people. And whose role is it? Because what we were kind of finding when we started to do a deeper drive is there's so many people looking at the patient in so many different ways. Sometimes it was confusing to us as a team on whose responsibility that one small piece was to identify these patients earlier. So because the pandemic hit and we got really busy doing a lot of other things, we have revisited this from time to time. What we're looking at is implementing a PPO pathway that's team-based with all our stakeholders to identify these patients earlier, look who's responsible for what at which point in the patient's care journey, and optimize the patients earlier. And then, see what that shows. This was another learning point for me, of course, is quality improvement. We might not get it right the first time around, and that's okay. It gives us the opportunity to go back and see where those opportunities are to improve during our Pdsa cycles. Key learning and reflections from this program. I absolutely love it. I think most of all, I really enjoyed meeting some of the people who participated in the program and the coaches and some of the very dynamic lectures. I really thought it was great to connect with people otherwise that I would connect in a normal working day in my department, in my area. I felt one of the learning things for me personally was that what seemed very simple, this project and how to do an AIM statement, when you start really drilling down, is a little more challenging than it appears on the surface. And the KISS principle, like keeping it simple, is important. The other thing I learned is that this might be my priority today, but the team has lots of other competing priorities. And we're all interested in quality and safety. But with so many competing priorities in healthcare, how do we drill this down and make it attractive to the stakeholders? The other really big thing for me is quality improvement is not research. I mean, I do a lot of research in other areas, and I thought, this is more quality improvement research because I do some of that, but it's certainly not. And there's such a difference. It's very dynamic. It's very fluid, and it's a whole different approach, and it's really, really exciting work. The other thing is I was glad throughout this program that they challenged me. I always joke that I grew up in the age of 1970 in Pong, so I was very glad that this program challenged me to continue to improve my skills using things like run sheets and different programs and audiovisual materials. And I just want to thank everybody else.
Good morning. I'm Jennifer Shi. I am a physiatrist at Saskatoon City Hospital. My project involved improving the length of stay in stroke rehab. To me, improving length of stay is really about good patient-centered care. At stroke rehab, there's two main reasons why we want to decrease length of stay. Number one is that our patients have a long road to recovery after their stroke. And if we can get them to a level of independence sooner, then we can get them back to living their lives sooner. Number two is that stroke rehab is really the only intervention that's been shown to improve function after stroke. And early access to rehab is critical for best outcomes. So by decreasing length of stay, we can allow earlier access for those who are waiting for rehab and therefore achieve better outcomes. I took a look back at our CIHI data, and I found that our length of stay was longer, yet our stroke patients had poorer functional gains compared to the rest of the country. This clearly was an area for improvement. So as a part of a much larger initiative to improve length of stay at rehab, our team focused on a subgroup of patients who we felt stayed longer because they had difficulties managing their medication safely as a result of their stroke deficits. A retrospective chart review confirmed our suspicions. These patients stayed 10 days longer. So our aim statement was to decrease this subgroup's length of stay from 42 days to 38 days. We had three primary drivers to help achieve our aim. And using a priority matrix, we decided to start with the communication process. Before our PDSA, we took a look at our data from May to December 2019, and we had 40 patients who were having difficulties with medications, but only 35% had documented medication goals. We implemented a simple solution where we added a preset so that medication management goals are flagged on the existing patient goal sheet. And we started a process. So this swim lane diagram outlines the interprofessional roles in identifying the goals as well as communication and documentation around the goals during team conferences. 1 month in, I completed a survey of the stroke interprofessional team, and everyone felt that this process was both easy and useful. And most people felt that it could shorten the length of stay, and the duration of team conference did not increase due to the new process. Unfortunately, since the pandemic, we have had to put this project on hold, so I don't have enough data to tell whether or not the changes we've made have led to an improvement in length of stay. Once we're able to resume the project, our next steps are to fine-tune our prior changes and then to develop a future state process map so that we can have a therapeutic medication management program for our patients to teach them how to take their medication safely prior to discharge. I have learned so much through CQIP, and one highlight for me is the importance of being able to see the problem clearly, because it really helps us make good decisions. Before CQIP, everyone thought that what we needed was a pharmacist so that the pharmacist could run a medication management program. And I just want to show you our fishbone diagram to highlight how complex the problem actually is. If we had only focused on that one component, I feel we would have really missed the mark on the solution. There was a large group of people who were involved with and supported this project, and I would just like to acknowledge their contributions. Thank you.
Good morning. My name is Leland Summer. I'm a nurse practitioner in Regina at Eden Care Communities. My project was focused originally on appropriate diabetes management and long-term care. Working with the team at Wascana Rehab, that location was chosen. And a key learning was the building of the team is key to any project and not to lead with the solution. The driver diagram was never created because the momentum was building. Senior leadership I had met with the management team and the physician team. And at this point, I had recruited a patient family advisor, and we had met a couple times. So the project was starting to get exciting. I was looking forward to meeting with the care team to really drive down into what the problems were, rather than lead with my own assumptions from what I thought I knew from what the evidence would say. And really a lot of this was clarified with working with the data analysis team through clinical appropriateness in Regina. So I truly appreciated how much they influenced and helped me realize what the project required. But of course, in March, COVID happened. And with the continuing care priority focus change and the cohorting impact, it was agreed at all levels that the project had to be put on pause. So a change in course occurred. Sitting at the table of the decision-making team for the emergency management leadership team at Eden Care Communities, a common thread seemed to always come out. There was too much information. The information that was out there was very hard to decipher and figure out what was important to our service locations. With this, I worked with the leadership team to really listen and learn what they wanted. And they wanted a quick picture. They wanted a snapshot so they could figure out what was going on in our locations of service and in the province. So the secondary drivers I would identify as all of those areas of information that were coming in. And one on this list I haven't included is the media, and that is a big influencer, whether or not it's accurate. But we had a continuous bouncing ball of data information from across the province, but very little was being filtered down to this is the picture in Regina, this is the picture in Saskatoon or Moose Jaw. So this made making decisions for the safety of the care partners and the safety of our elders very challenging. And as an affiliate, we carry a different risk than, say, an owned and operated long-term care. One big piece through this was early on, I started to realize that there are many different pandemics happening within our own province. And through the creation of this driver diagram, that shone through. And the importance of creating something that created a snapshot to influence decisions was developed and born. This was the dashboard that came from all of the discussions with the team. The first dashboard, which definitely didn't look like this, was sent out by email August 21st. And I firstly want to say I wish we could go back to those numbers compared to where we are right now. With that first presentation of the dashboard, I made a presentation to our Regina area special care home affiliates and allowed them to ask questions, allowed them to give feedback. This snapshot they truly appreciated because it was something that they could see in their email, they could review at their leisure, and get a very quick detail of what was occurring and what the trends were. This current of variation is emailed daily to a group that has requested it. The metrics were incorporated for the cities, which then gives a very quick view of the prevalence. This was not being done, and it's still not really being done at the provincial level. The color coding provides a quick idea of what the risk is. With the current, sorry, lost my mouse. QI is adaptable throughout the clinic and healthcare environment. Truly, I've learned to listen to what is needed, wanted, and attainable, and I'm completely impressed by the system of QI thinkers we've built. And I've learned that assumptions are the downfall to any great idea. So never lead with an assumption or a solution. Listen to what is wanted.
Good morning, everyone. My name is Sinisha Zaraik. I'm a family physician in Saskatoon, and our project looked at improving identification of depression and anxiety in patients with diabetes. So when it comes to patients with diabetes, we know that psychiatric comorbidities can have a negative impact on blood sugar control, diabetes-related complications, as well as quality of life. And unfortunately, it is apparent that depression and anxiety remain underdiagnosed in this patient population. Therefore, it's not surprising that Canadian diabetes guidelines recommend regular screening for psychiatric conditions in patients with diabetes. So as it turns out, at our clinic, the Westlands Primary Health Center, we could be doing a better job when it comes to screening for depression, anxiety, in diabetic patients. Screening rates for eligible patients are around 60%. However, it is not clear how the screening is done, and rate of utilization of validated questionnaires is almost zero. So it is more likely that during a busy visit when many other issues need to be discussed, diagnosis will be missed or delayed, as there is often very limited time to appropriately screen for these conditions. So our aim statement was to increase screening rates for depression and anxiety in patients with diabetes at our clinic to more than 90% by August of 2020. And we also aim to standardize this process by using validated questionnaires. So we came up with our first Pdsa cycle, where we used clinical decision supports available in the EMR to automate the process of identification of patients who require screening. So we used questionnaires PHQ-9 for depression and GAD-7 for anxiety to screen patients, and these would be given to them to complete prior to the CDM visit. And we established a workflow where, depending on the results, another visit could be scheduled to address mental health concerns, or if red flags were present, those would be addressed right away. And as a balancing measure, we looked at any perceived negative impact on the workflow. So unfortunately, we didn't get very far. The start of our Pdsa cycle coincided with the beginning of the pandemic, and within a week of when we began, everything shut down and things basically came to a halt. And unfortunately, we haven't been able to restart the project. So in the future, if the project is restarted, we could look at developing a process that will consider the new reality of virtual care and how to incorporate screening into virtual visits. We could also look at whether increased screening rates resulted in a significant number of patients being identified with depression and anxiety who were previously undiagnosed. And ultimately, we can look at whether this actually resulted in improvement in diabetes-related outcomes. So some of the things I've learned through this process is that it's helpful to go into a QI project with an open mind and to be open to change, but also with the mindset that there will be obstacles along the way. And being open to change and working through these obstacles is the only way to advance the project forward and ultimately grow as an individual and improve your skills. Thank you.
That brings us to the end of our quick talks. Thank you to all the quick talk presenters. Your presentations are a culmination of a lot of work, but as we've heard today in what you've shared, this is just the beginning for you as quality improvement leaders and champions. One of the things that I heard a lot is that we should not start off with solutions, but that we should get to know the problem better. And that is a lesson that I think we can all take on our QI journeys. Now it is my great honor to introduce our keynote speaker, Dr. Gary Gruit, who is a physician leader that I have great admiration for. Dr. Gary Gruit is first and foremost the father of 4 wonderful boys. Next in the order of importance, he's a clinician with a passion for his patients. In his spare time, Gary has developed a hobby of sorts, clinical quality improvement. Dr. Gruit holds a joint appointment at the University of Saskatchewan in Surgery and Community Health and Epidemiology, and is the clinical co-lead for the Saskatchewan Health Authority's QI program situated within the clinical standards portfolio. Gary began his practice in Africa prior to his general surgery training at the University of Saskatchewan. Following his surgical oncology training in Winnipeg, he returned to Saskatchewan, where he has practiced since. Following 5 years as the head of surgery for the Saskatoon Health Region, Dr. Gruit completed a PhD in the Department of Community Health and Epidemiology that in turn led to his current job appointment. The realization that system-level change supporting clinicians to do the right thing for their patients is the future of healthcare sustainability prompted Gary's involvement in a clinical quality improvement as an educator, researcher, and practitioner. Dr. Gary Gruit.
Thanks, Philip. And wow, all I can say is those were amazing presentations. You know, I spent the whole 4 cohorts or the whole cohort time with all of you, and it just sounds so different when I hear them back to back like that and reaching various levels of completion. Very impressive work, and thank you all for your presentations. We're here kind of as a part of the capstone just to highlight some of the learnings that you've done, and I'm going to build on what I heard from a lot of the learnings that came from your projects that you had. One of those learnings actually is this the delay in this capstone even, and because of the pandemic and having to convert to this sort of unusual and almost weird way of doing presentations is kind of it's a bit sad in a way, but it also serves as a living example of the kind of flexibility and openness to change that really is embodied by clinical quality improvement. I want to say thank you to the organizers at the very beginning for the land acknowledgement. But for me personally, I just want to say that it's easy. I don't know about anybody else, but it's easy for us to do these land acknowledgements and just forget to make them personalized. Those words are easily and quickly lose their meaning if we don't stop and think about what they mean for us, what it means for me. Because I grew up, I don't know about you, but I grew up thinking of land as a commodity to be bought and sold, not as a borrowed gift to be used respectfully. And I acknowledge that I personally have a long way yet in my journey to fully understand what it means to truly pay my respects to the ancestors of this land. So I let that land acknowledgement be my baby step towards a personal journey towards reconciliation that I think we all need to keep in the forefront of our vision. A short time ago, I was invited to participate in a power hour that the HQC put on that was centered on the CQIP program. And this slide comes from that power hour. And it listed off some of the unique aspects of a QI training program that we have here in Saskatchewan. And I totally agree with all of these important aspects of why CQIP is special. There's no question about that. But I think if you look under the hood, so to speak, I think you'll find that there's something even more amazing than these things that make CQIP special. And I think that what lies under the hood is the passion that each of you have. And I most certainly heard that passion this morning as you talked about the projects that you were working on. And I think it's that passion that really makes CQIP successful. It's actually all of you and the reason that makes you want to come in the first place, to take your time out and to learn about quality improvement, to become a QI leader that I think is the real reason. And it's not, if you'll notice that we start to see a change over the years that I've been involved with CQIP, is that initially it was entirely physicians that were at the table, and now we're starting to see a broader mix of clinicians, including nurse practitioners and pharmacists and others. And I think that's awesome. And just broadens that idea of passion. As Philip mentioned, I am a general surgical oncologist, and I bring that same passion as you do to do the best possible care for my patients to my work. And it's our patients that at the end of the day are the source of that passion I think for pretty much all of you as I've gotten to know you. It's what brings us joy. It's what put a smile on my face with this gentleman that I didn't show his original pre-operative pictures of, but it's those patient interactions and knowing that we're doing the best we can for our patients that drives us to do the work that we do. Over the last several months or the year or so since we started with this cohort, but also with all the preceding cohorts, I can tell you that I have had enough interactions with all of you to know that you have that same kind of passion to make your world a better place, and that I think is one of those key motivators. When I first started my practice, as Philip mentioned, I started in Zaire in Africa. And I was passionate there too. I get excited about what I do, and I get very passionate about it. And one of the things that I noticed when I was there, I was working in a city the size of Saskatoon. I was one of two physicians. There was myself and one African physician, and we really struggled because we were small, but I couldn't pay my nurses a living salary. The salary we paid them was enough to supplement their subsistence life that they had already. And it just seemed to me to be a big problem because it resulted in my nurses asking for bribes from patients. And I sat them down and I said, can we fix this? And we spent about 6 months negotiating a different salary structure for them. And they were excited and I was excited. And the day before I implemented that change, I got a knock on my door in the evening from the governor of the area who had heard of what was happening. And he said, I can't let you do that. Because if you do that, everybody else is going to expect the same thing. And I felt like this picture here. I felt like it was like just this absolute chaos, and how could I allow for that to happen? And he said, no, I'm sorry. If you do that, I'm going to have to ask you to leave the country. I mean, it was a big deal, and it was very demoralizing for me. And it took me years to understand, literally years after I came home, but to understand that I had failed. And I had failed to understand that those kind of system changes, that really making a difference is a team sport. And I think that's one of the reasons that CQIP is attractive as well, is because it gives us the tools to understand that system change and patient care is not an individual event, it's a team sport. And it's a team sport that involves all of our colleagues in different disciplines, radiology, pharmacy, nursing, but it's also a team sport that involves the people that we're going to ask to implement some change that we're passionate about. And if we haven't engaged them right from the beginning, then it's just not going to happen. One of the other reasons I think that CQIP is so attractive is that and why it's successful, is that CQIP is intuitive to clinicians. You're presented with a problem, you analyze it, you come up with a differential diagnosis, if you will, and then you investigate to see which is probably the best differential diagnosis, and then you go about doing something about it, which is, in the clinical world, a treatment option. You assess whether that worked or not, and if it didn't, you readjust and you carry on. So it's very intuitive for clinicians. And I think one of the other big differences between evidence-based medicine, which is what I grew up with, and the clinical QI is the reliance on local data to modify evidence to live in the real world. For many, many, many years, and even when I was department head in Saskatoon, what we would do is we convene a panel of experts to come up with a solution. That solution would get implemented, and then it sat there, never evaluated to see whether it worked or not, and never to be changed. And even if it was wrong, it sat there. And clinical QI invites us to do a similar piece of work, but take it to the next step where you say, okay, let's look at how that intervention that you created works. And did it actually work the way you thought it did? And if not, do something different. And I think that also makes people feel happy, and it makes us more likely to see things be implemented and be successful. So what I just described to you is actually what I understand to be a learning health system. This is something that's being talked about more all the time. And it is this notion that we not only take knowledge and implement it, but then we evaluate that implementation, modify it, and do the cycle over again. And it's using what might be known to work in Ontario, adapting it to Saskatchewan, checking to see if it works in Saskatchewan, and then making the changes as required. You'll see a learning health system depends on a lot of core values that are shared across the board, and it results in better patient experience, better provider experience, and an improvement in healthcare costs as well. And I think this is where QI sort of plugs in and fits in. And I think that the fact that we've moved beyond just evidence-informed or evidence-based medicine to this more living way of doing things is going to create success for us as well. CQIP rather, is designed to give you the tools to do quality improvement. And as you can see, you can probably find yourself represented in all these sort of categories of people who've done CQIP projects over the years, either reducing variation, improving processes, improving safety and reliability, improving experiences. And I can see in this group, as well as all the CQIP groups before you, that you will go forward and you are going to do amazing things in terms of changing the system, to making it better, to improving it. And that takes time, but yes, it happens. Many of your projects will either continue on after you're finished today, or will give you the tools to go on and do other projects. And we really look forward to seeing all of you continue to be involved with quality improvement and to be leaders in quality improvement. One of the things I've learned over the years is system change is hard. System change takes time. And you are uniquely positioned right now in a system that has going through a change slowly over the last 10 to 20 years. We're now in the process of developing a structure within the health authority that's going to connect quality improvement to the operational side. Will make doing quality improvement even that much better, that much easier. We're in a process of we'll be looking to say, how do we provide those of you that are leading quality improvement projects at a higher level the data support you need? Because as you all discovered, you can't do this work without having data support. And how can you be embedded in a system that wants to do the same changes you want to do? Those are all really important infrastructure changes that are in the process of happening. And then, of course, there's that whole tipping point concept where we are in the process, I think, in Saskatchewan of embedding QI into the culture of the Saskatchewan Health Authority and the culture of healthcare in Saskatchewan. It's going to take time. It's not going to happen overnight. But I think we're at the cusp of being ready to do that. And our next steps will be to take us to the next level in this regard. Part of that is ongoing capacity building so that people like you can do the work that needs to be done. I'm so grateful that we have the funding and negotiated between the SMA and the government to continue to fund this ongoing capacity building. And I encourage each and every one of you to stay with us, to be engaged, to come forward and offer your new leadership skills to the system at whatever level is appropriate for you. And it'd be great to continue to work with all of you going into the future. Thank you very much.
Thank you, Dr. Gruit, for those words of wisdom. What stood out for me was it is passion that leads us here to quality improvement. Also, system change is a team sport. What we want to be is we want to be part of a learning health system where we do continuous evaluation of what we're doing and then adjusting as we go forward. Thanks again, Dr. Gruit. So thank you to the participants for their engagement in the program and your commitment to lifelong learning and your contributions to making our healthcare system better. It's been an 18 months of hard work, and that is what brought us here. Now there's going to be a little something to reward you for your success. Each of you will receive a framed certificate in the mail shortly after this, and then a second item that you will receive that is something that you might have heard about is the coveted QI socks that you'll receive as well. So that is something to be looking forward to in the mail. And on that celebrity note, I would officially close the Capstone program for today. I would like to thank you for joining us and stay safe, everyone.